Hi, my name is Jocelyn Luzardo, and I'm going to talk about randomized trial of endoscopic or open vein graft harvesting for coronary artery bypass. Definition: the saphenous vein graft is the most common conduit for coronary artery bypass grafting. The influence of the vein graft harvesting technique on long-term clinical outcomes has not been well characterized.
This study showed no difference in outcomes in terms of major adverse cardiovascular events in patients who had saphenous vein graft harvested endoscopically versus open in a randomized trial. It also showed that there was reduced risk of wound complications in the patients that had endoscopic harvesting. I think this trial opens the question for further investigation, a larger study, more patients of diverse, not only gender, as this study was largely male, but also a larger group of patients with multiple comorbidities who may have had multi-vessel disease. So I think it opens the question for further study. Any longer-term follow-up we could have would be beneficial. In addition, data on patency would also be very helpful. The use of one arterial conduit is now a quality measure and is mandated, and that data is publicly reported for surgeons. So we know that the use of the left internal mammary artery to the left anterior descending should be done in all patients, if possible, undergoing coronary artery bypass grafting. And there are a lot of data now that suggests arterial grafting is beneficial to survival and for patency over the long term. So the longer term data that we would have, the more information we would know. However, vein grafts will always be in our armamentarium if arterial grafts are insufficient or inadequate, or, for example, do not provide adequate flow in an emergency situation. So we will always want to know, would it be better to harvest it open or endoscopic, or with small bridging incisions? Different surgeons are driven by different motivational factors. Time is one of them, whether or not they believe the data, the literature, and that arterial grafting provides prolonged survival and better patency compared to vein grafting. Also, many of us work at teaching institutions, and doing all arterial grafting takes a little bit more time and is technically a little bit more challenging and may be more difficult to teach in contrast to a vein graft.
Applications in medicine. The rationale and design of the trial have been published previously. Cardiac surgery programs and Veterans Affairs medical centers with expertise in performing endoscopic vein graft harvesting were eligible to participate, and Executive was responsible for the trial oversight. Pros and cons. Pros. It reduces the complications related to the operate one of the removal of the saphenous vein because a 2 centimeter incision is made instead of 10 and 50 incisions. Less infection, discomfort, and pain. Shorter hospitalization and lower overall costs. Cons. There may be possible complications such as bleeding or infection at the collection site.
That means a bypass operation. So vessels can be harvested from the leg or from the arm endoscopically. The incision is 1 centimeter, so which causes patient recovery becomes much faster, and there is hardly any scar there, and patient satisfaction and recovery is very good.
Issue of plague in Ecuador. Furthermore, Vein-Graft patency has been consistently lower with endoscopic harvesting than with the non-endoscopic harvesting possible because of mechanical factors during procurement performed by inexperienced endoscopic harvester.
A coronary artery bypass graft, or CABG, is performed to improve circulation to the heart muscle in people with severe coronary artery disease. In this procedure, a healthy artery or vein from another part of the body is connected or grafted to the blocked coronary artery. The grafted artery or vein bypasses the blocked portion of the coronary artery, carrying oxygen-rich blood to the heart muscle. One or more coronary arteries may be bypassed during a single operation. Before the surgery, an intravenous line will be started, and you may be given a medication to help you relax. CABG procedures are done under general anesthesia, which will put you to sleep for the duration of the operation. A breathing tube will be inserted through your mouth and into your throat to help you breathe. A catheter will be placed in your bladder to drain your urine. Coronary artery bypass surgery generally takes 3 to 6 hours. During a conventional bypass surgery, your surgeon begins by making an incision in the skin over your breastbone or sternum. He or she will then cut the sternum and move your rib cage in order to get to your heart. Throughout the procedure, your circulatory system will be connected to a cardiopulmonary bypass pump, or heart-lung machine. This machine temporarily performs the functions of your heart and lungs during the surgery, allowing your heart to be stopped while the surgeon sews the grafts into place. One of 2 blood vessels is typically used for the grafts: the internal thoracic artery in the chest or the saphenous vein in the leg. For the internal thoracic artery graft, your surgeon will leave the upper end attached to the subclavian artery and divert the lower end from your chest wall to your coronary artery, just beyond the blockage. Your surgeon will then sew the graft into place. For the saphenous vein graft, your surgeon will suture one end to the aorta and the other end to the narrowed artery just beyond the blockage. With the graft securely in place, your surgeon will use electrical signals to restore the heartbeat and attach a temporary pacemaker to the heart. Once your heart is again beating normally, the heart-lung machine will be disconnected. Your surgeon will wire the breastbone back together and suture the skin incision closed. A temporary drainage tube will be placed through the skin beneath the incision. 2 other types of CABG procedures have recently been developed: off-pump and minimally invasive bypass surgery. Off-pump CABG is also called beating heart bypass grafting because the heart isn't stopped and a heart-lung machine isn't used. Instead, a mechanical device is used to steady the part of the heart where grafting is being done. Surgeons perform minimally invasive bypass procedures using specially designed instruments inserted through small incisions or ports in the chest. These procedures sometimes require a heart-lung machine. After surgery, You will be taken to the intensive care unit. The activity of your heart will be carefully monitored. If necessary, the pacing wires will be used to temporarily control your heart rate. The chest tube will remain in place to drain excess blood and air from the chest cavity. Once you can breathe on your own, your breathing tube will be removed and replaced with an oxygen mask. The bladder catheter will remain in place. As you recover over the next 3 to 4 days, all of these devices will be gradually removed.
Thanks for watching.